tiempo demasiado. Pero siempre es un gusto estar con él porque cuando le gusta algo lo transmite y lo transmite disfrutando. Y entonces yo también, a pesar de que le conozco hace poco tiempo, pues sigo disfrutando con él, ¿no? Bueno, vamos a seguir, estar tranquilos porque no vamos a acabar a las 12 de la noche, aunque vamos con retraso, porque hemos decidido que lo que es la mesa, que era un poco de hablar de ultrasonidos y de resonancia, lo que vamos a hacer que sea un rato de cambiar impresiones y decir, no es que sea uno mejor que el otro, sino que, bueno, que las preguntas que van surgiendo aquí, pues las podamos realizar al final, o sea que vamos a modificar un poco esto. El siguiente ponente es Giovanni Lughezzani, está en el hospital Humanitas Research ahí en Milán. Lo hemos conocido a través también de que nos enteramos que estaban trabajando con el mismo equipo que nosotros y que ellos también tenían su experiencia, nos pusimos en contacto con ellos y la verdad es que ha sido también un gusto ver primero su disponibilidad a estar con nosotros y luego también pues que están teniendo unos resultados pues similares a lo que estamos haciendo nosotros. Entonces, Giovanni, your time.
Muchas gracias again. It's a real pleasure for me to be here. I will talk about our experience, a very initial experience with the micro ultrasound at my institution that, as Dr. Asveta was saying, is a Humanitas Research Hospital in Milano. So we have already seen some slides about technology. So we have seen the improvements of this technique as compared to the standard low-resolution ultrasound. This improvement indeed results in a possibility to see in great details a lot of change in the texture of the prostate. However, I have to tell you, first of all, that these changes in details sometimes, especially at the very beginning of my experience, can be frustrating, as you may see lots of lesions that are not real lesions. What we need to know before talking about our experience, we already seen this primus, that is a nice protocol in order to stratify the risk of having clinically significant prostate cancer. At the very end, what we did is to start performing this macro ultrasound examination to all of the patients that were referred to our clinic for suspicious prostate cancer. So this is a cohort that was collected in approximately 2 months. It represents a real-life clinical scenario as patients were sent to our department for a clinical suspicious of prostate cancer, coming either from an elevated total PSA or a suspicious digital rectal examination, or also to a presence of a suspicious lesion at multiparametric MRI. At the very end, we collected 95 consecutive patients. The median age was 64 years old, and the median total PSA level was almost 7 nanogram per milliliter. 24.2% of these patients had a positive or suspicious digital rectal examination, and 60 patients had a positive or suspicious multiparametric MRI. Almost half of these patients were also in the repeat biopsy setting, so had undergone at least one previous randomized biopsy. So going to the results, these are our results in terms of lesion distribution. So you can clearly see that we saw lots of lesions, probably too many lesions. Almost 80% of the population has a suspicious findings at micro ultrasound, while 20 patients actually had a negative primus 1 to 2 findings. We took more than 1,000 cores in total, and more than 200 of these were positive. And the cancer detection rate, the overall cancer detection rate in our group was 52%. But when we look at the clinical significant prostate cancer, defined as cancer with a Gleason score of 7 or more, we have 28, so 57% of these patients had a clinically significant prostate cancer. We then go and look at the relationship between the Primus score and, first of all, the overall prostate cancer diagnosis. So we can see that it tends to be a relationship, but still is not that striking. What it becomes more evident is when we look at clinically significant prostate cancer. So we can clearly see that for patients having a Primus 1 to 2 or Primus 3 lesion, there are very few clinically significant prostate cancer, while this percentage was way higher when looking at Primus 4 and 5 lesions. So we go to the diagnostic performance of this test. So you can clearly see from our results that the sensitivity and negative predictive value are pretty high, more than 90%, but the specificity and positive predictive value tend to be way lower. And I think that part of these may be attributed to the initial learning curve phase that, as I told you, give you a lot of false positive results. We then look at the subpopulation of patients with a suspicious multiparametric MRI. So this is the distribution of the PARA score across our population. So the first thing that we look at was if there was any correlation between the Primus score and the PARA score. And actually there was a trend towards a higher Primus score and a higher PARA score, but this was not that striking. What we have to keep in mind, especially when considering this data, is that unfortunately in our center we don't have just one uroradiologist, and since a lot of patients come with a multiparametric MRI that has been performed in other centers, unfortunately most of the time we are not reviewing the results of multiparametric MRI with our radiologist, and that indeed affect our results. So you can see that there is the distribution of overall prostate cancer diagnosis according to the different PARAS score, but again, when we look at the clinical significant prostate cancer percentage, the performance of multiparametric MRI in our population, keeping in mind all the limitations of this population, is not that striking. We then look at what happens when the relationship between micro ultrasound results and multiparametric MRI results. And of the 14 patients that had a positive multiparametric MRI and a negative micro ultrasound examination, 8 of them harbor prostate cancer, but only one was a clinically significant prostate cancer. The concordance rate between micro-US and multiparametric MRIs was pretty good in terms of determining the presence of lesions, so it was 72%. And of the 13 discordant cases, actually 6 did not harbor a prostate cancer and 3 harbor a low-grade prostate cancer. 2 patients had a transitional zone clinically significant prostate cancer that was diagnosed with the fusion biopsy. So this is indeed a limitation of the technique. 1 patient had a Gleason score 3+4 detected by macro-US only, and 1 patient had actually a Gleason score 3+4 disease that was got by random cohorts only. Finally, I just want to show you some few cases that I think are kind of explicative of our experience. So this, for example, was a patient 72 years old with a negative digital rectal examination and a previous biopsy that was a low-risk disease in 3 out of 12 cores. So this patient was enrolled in active surveillance. There was a slight increase in his PSA levels, He performed a multiparametric MRI that showed a Paras 5 left apical lesion and a Paras 3 lesion in the right apex. And this is the micro-ultrasound. So actually you can see here a Primus 5 lesion in the anterior zone of the prostate. And this lesion was actually biopsied by myself. Here you can see. And these were the pathologic results. So actually this man was diagnosed with a glioblastoma 4+3 cancer in the 2 target cores, while all the random cores were negative. Another case, this guy is 61 years old, a total PSA of 6.4, negative digital rectal examination. This man had a Gleason score 3+4 in 2 out of 12 biopsies, just a micro focus of disease. But he was subjected to a pathology review that downgraded this disease to a 3+3 disease. So again, he was enrolled in an active surveillance protocol. This is a multiparametric MRI, show you a clear Paras 4 lesion in the right lateral lobe. And this is the micro-ultrasound result. So actually, what you can see here is the prior needle track that almost missed the lesion. The lesion is a Primus 4 again in the apical region, as you can see also from this video clip here. And the biopsy results gave us a 3+4 prostate cancer in 2 target and actually also 2 random cores, but the percentage of positive cores involvement was way higher in the target biopsy. And finally, last case, 59 years old, a total PSA of 6.5 and a negative digital rectal examination. This was diagnosed with a 3+4 disease, but this man did not want to undergo surgery, so he performed a multiparametric MRI that showed a suspicious hypointense lesion, but again with a problem of standardization, no Paras here was reported. And here you can see the micro-ultrasound result, so you can clearly see a Primus 5 hypoechoic lesion in the right base of the prostate. We perform a biopsy again of this lesion, and these were the pathologic results where you can see that there was a 3+4 lesion in the target cores, and this patient at the very end underwent a radical prostatectomy. So I want to conclude my talk with some messages. So I will say that in our first clinical experience, micro-ultrasound appears to be a valid tool in the diagnosis of clinically significant prostate cancer. And actually, these results come mainly from its high sensitivity and negative predictive value, while its specificity it's indeed still low, and probably due in part to the initial learning curve phase. Additionally, micro-US and multiparametric MRI showed a fairly good concordance rate, but the latter was more effective in diagnosing the cancers in the transitional zone. And thank you for your attention.
Thank you very much.